Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Good morning, Dr. Stevens. I wanted to discuss a few issues that have been bothering me lately, especially about my foot and my diabetes management.
Good morning. I'm here to help. Let's start with your foot. Can you tell me more about the current situation and your past treatments?
Sure. Since my accident back in 2008, I've had ongoing problems with my foot. I've undergone multiple surgeries to manage the damage, and I still have surgical pins in my foot. Lately, the pain has increased, and it's affecting my mobility even more. There's also this persistent problem with toenail avulsion, which has been very uncomfortable.
I see. And how has this affected your daily activities?
It's been quite challenging. The pain limits my walking and standing times. I've tried using TED hose for the swelling, but they're difficult to put on and only offer slight relief. I'm really hoping we can look into options for possibly removing the pins if that could help reduce the pain.
Thank you for sharing that. It helps me understand the scope of your foot issues. Let's also talk about your diabetes management. How have you been managing your blood sugar levels recently?
Well, my blood sugar levels have been quite high. I'm currently on metformin, but my last HbA1c was 8.5, and I saw in the lab results that it's gone up to 8.7 now. I try to control my diet, and I've actually lost some weight through portion control, but it seems like it's not enough. I've been consistent with my medications recently, though I know I've had problems with adherence in the past.
That's a good step forward with the weight loss and medication adherence. It's important for your overall health, especially with your diabetes. How do you feel about your current regimen for managing blood sugar?
To be honest, it's frustrating. I feel like no matter what I do, my sugar levels are still out of control. I'm willing to try adjusting my insulin doses, but I'd prefer to do that with more frequent checkups if possible.
I understand your frustration. Managing diabetes effectively can be challenging, especially with other health issues in play. Let's make sure we address all these points today. Do you have any other concerns or anything else you've noticed health-wise?
Well, my mobility issues have made it difficult to stay as active as I'd like, which probably doesn't help with my diabetes. Also, I've noticed some changes in the coloration and swelling in my foot since the accident, and despite using the compression stockings, it hasn't improved much.
Thank you for all the details. It's clear we need a comprehensive approach to manage these issues. Let's go over your clinical values from the recent tests and outline our next steps. Your blood pressure is stable at 128/78 mm Hg. but your BMI at 32.5 indicates that we need to continue focusing on weight management. Your blood sugar levels are still high, with fasting glucose at 198 mg/L and postprandial at 220 mg/L. Your HbA1c has slightly increased to 8.7%, which confirms your concern about your diabetes control. Your cholesterol levels are slightly elevated with a total cholesterol of 205 mg/dL. We should keep an eye on that, especially your LDL at 130 mg/dL. Your kidney function shows some concern with a creatinine of 1.6 mg/L and an eGFR of 45, indicating moderate chronic kidney disease. The albumin to creatinine ratio is also elevated, suggesting some kidney stress, likely related to your diabetes. Here's what I propose. We'll refer you to podiatry to evaluate the possibility of removing those pins in your foot, which might help reduce the pain and improve your mobility. We'll also schedule you for a follow-up with orthopedics to address the structural issues and the toenail problem. Regarding your diabetes, I recommend we intensify your treatment. This could mean adjusting your insulin regimen and possibly adding other medications to better control your blood sugar. We'll schedule more frequent follow-ups to closely monitor this adjustment. I also want you to see an eye doctor given the diabetes-related risks, and ensure you reschedule with the liver specialist to follow up on your overall health. How does that sound?
That sounds comprehensive, Dr. Stevens. I appreciate the detailed plan, and I'm hopeful that with these adjustments and additional monitoring, we can better manage these issues. Thank you for your help today.
You're welcome. It's important that we tackle these issues together. I'll make sure all the referrals and follow-up appointments are set up before you leave today. Let's keep in close communication about your treatment progress.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Good morning, doctor. I've been having a rough time with dizziness, especially in the mornings. It usually happens before I take my medications, and it's getting quite concerning. It doesn't seem to relate directly to my meals or even my blood sugar levels, which are sometimes high when this happens.
Good morning, Alex. I understand that must be quite challenging. Can you tell me a bit more about when this dizziness started becoming more frequent?
It's been a few months now. Initially, it was just now and then, but it's become more frequent over the past few weeks. I've noticed it mainly occurs right before my morning medications. I've been on hydralazine for my blood pressure, and I had to reduce it from 3 times a day to twice because it was making the dizziness worse.
That's good to know. You mentioned adjusting the hydralazine helped a bit, but you're still experiencing dizziness. Have there been any recent changes to your other medications or your overall health that might be contributing?
Well, I've been trying to manage my medications better by shifting some doses around. For example, I moved my atenolol to the night, thinking it might help, but my cardiologist suggested trying it in the morning instead. We also stopped niacin a while back and replaced it with fish oil on his advice. Other than that, I've been dealing with a scratch on my leg that got a bit red, but it's being treated and doesn't seem to be infected.
I see. Managing medication timing can indeed influence how you feel. It's good to hear that the leg is not showing signs of serious infection. Have you noticed any other symptoms that accompany the dizziness, like ringing in your ears or changes in your vision?
No, nothing like that. Just the dizziness, really. It can be quite severe, but it usually settles down after I get moving. My dermatologist used a treatment for some skin lesions last month, but I don't think it's related.
Okay, thank you for sharing all of this, Alex. Let's look at some of your recent clinical metrics to see if there's anything else we need to consider today. Your average blood pressure has been around 145/67 mmHg, which is a bit high, and we'll need to keep monitoring that closely. Your heart rate has been stable, and your weight is being regularly tracked. Regarding your lab results, your morning blood sugars have been around 140 mg/G with some fluctuations, and your cholesterol levels were slightly elevated at the last check. We're also keeping an eye on your kidney function because of the medications you're on, particularly hydralazine and fosinopril.
That makes sense. I'm hoping we can find a way to manage these morning dizziness episodes better. It's quite unsettling and makes starting the day difficult.
Absolutely. I can understand that. Given your symptoms and the concerns you've raised, I think it would be prudent to continue with our plan to adjust your medication timings under close observation. We'll monitor how the shift of atenolol to the morning affects you. Additionally, considering your history of cardiovascular issues and the persistent dizziness, I would recommend scheduling an echocardiogram to assess your heart function more thoroughly. This will help us ensure there isn't a cardiac component contributing to your symptoms.
That sounds like a good plan. I'm glad we're looking into this further. It's important for me to feel stable, especially in the mornings.
Definitely. We'll schedule a follow-up in a few months to evaluate the effectiveness of the medication adjustments and the results of the echocardiogram. I also suggest continuing with the advice to move slowly in the mornings to help manage the dizziness. In the meantime, we'll arrange for your upcoming audiology and gastrointestinal consultations as routine checks.
Thank you, Doctor. I appreciate you helping me figure this out. It's reassuring to know we have a plan moving forward.
You're welcome, Alex. It's important to us that you feel supported and that we address these issues comprehensively. We'll be in touch about the dates for your echocardiogram and the next steps. Take care until then.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Good morning, everyone. Today we're addressing the legal frameworks surrounding workplace inclusion, specifically focusing on the Disabilities Act, which mandates reasonable accommodations for employees with disabilities.
Absolutely. It's crucial that these accommodations not only meet legal standards, but also effectively support the individual needs of our employees, providing accessible workstations, flexible work hours, and necessary technology aids are significant steps toward enhancing inclusivity.
Indeed, and we must also consider the broader impact on our workplace culture. Encouraging an environment where everyone, regardless of ability, can thrive is not only a legal requirement, but also a best practice that leads to greater employee satisfaction and productivity.
To ensure compliance and effectiveness, we should regularly conduct training sessions for our management and audit our practices. Understanding the depth of these laws helps us implement them better, and proactive management of these issues will protect us against potential lawsuits and enhance workplace harmony.
I agree. And let's also talk about conflict resolution and the role of HR in facilitating discussions around accommodations. It's important for all staff to know where to go for help and to feel comfortable seeking accommodations without fear of stigma.
Now look at question 26.
With the ongoing heat wave, we've seen a notable increase in admissions, particularly among the elderly and those with pre-existing conditions. Our current infrastructure is under stress, and we need strategies to manage this effectively.
Setting up hydration stations and additional cooling areas within emergency and waiting areas is a start. We should also consider extended clinic hours to manage the overflow without overburdening our current staff.
Additionally, we could work with local health departments to issue warnings and prevention tips for heat-related illnesses. Public education could help reduce the number of people needing urgent care.
On the internal front, ensuring our staff have regular breaks and access to hydration is crucial to maintain our care standards. Overworked staff can lead to mistakes and decreased care quality.
Let's also increase our stock of necessary medical supplies like IV fluids and portable fans to ensure we're prepared for continued high temperatures. Coordination with local authorities and community health workers will be key in managing this crisis.
Now look at question 27.
For our infant patient in room 204, we need a comprehensive care plan that addresses all current health concerns. The baby has shown some improvements, but the situation remains delicate and requires our full attention.
I recommend increasing our monitoring, possibly with more frequent checks. Weight and intake need to be closely watched to ensure the baby is receiving sufficient nutrition, particularly given the recent feeding issues.
I agree, and involving a pediatric nutritionist could provide us with more tailored feeding strategies. Additionally, scheduling more regular consultations with pediatric specialists could help us track and stimulate developmental progress more effectively.
We should also consider the parents' involvement in the care process. Educating them about daily care techniques and what signs to watch for can be crucial, especially once the baby is home.
Lastly, let's ensure all team members are updated with the latest information after each shift. Effective communication will be key to providing consistent and comprehensive care.
Now look at question 28.
In our triage process, prioritizing patients effectively remains a challenge, especially under resource constraints. It's essential that we refine our protocols to ensure those most in need receive care first.
We must also consider potential for deterioration. Patients presenting with conditions that could escalate quickly should possibly be prioritized, even if they appear stable initially.
That's an excellent point. We need dynamic triage criteria that can adapt to changing circumstances. Maybe incorporating more detailed patient histories and predictive indicators into our initial assessments could help.
I support that. Perhaps enhancing our triage training to include simulations of high-pressure scenarios could better prepare our staff for these critical decisions.
And let's not overlook the ethical dimensions here. We should also have regular reviews of our triage decisions to ensure fairness and learn from any mistakes. Continuous improvement in our processes is crucial.
Now look at question 29.
I've noticed your reports of increased fatigue, and it's important that we address this comprehensively. Fatigue can be multifactorial, so we'll need to examine various aspects of your health and lifestyle.
I've been struggling with it, and it's starting to interfere with my daily activities. I'm not sure what's causing it or how to manage it.
Let's start by reviewing your current medications. Some can contribute to fatigue. We'll also look at your diet, exercise patterns, and sleep quality. Sometimes small changes in lifestyle can significantly impact energy levels.
I'm open to making changes. I haven't been exercising much lately, and my sleep hasn't been great either.
Improving your sleep hygiene and incorporating moderate exercise could help boost your energy. Additionally, we should consider whether a referral to a specialist is needed, depending on the outcomes of our initial adjustments.
Now look at question 30.
As clinicians, we have an ethical duty to recognize and mitigate our biases in patient care. Our decisions should be informed by the best available evidence, not our personal or cultural biases.
While I agree with the need for awareness, I believe that implementing standardized clinical guidelines can further help in reducing individual biases. These guidelines ensure that all patients receive care based on the same best practices, regardless of who is treating them.
Guidelines are helpful, but they are not a panacea. We also need to commit to ongoing education and self-reflection. This includes training on cultural competence and implicit bias.
Absolutely, and we should also be analyzing our patient outcome data by demographics to identify any patterns of disparity. This can highlight areas where biases may be influencing clinical decisions and outcomes.
Implementing feedback mechanisms where patients can report on their experiences and perceptions of bias could also provide valuable insights for improving our practices.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at extract 1.
Welcome everyone to today's advanced seminar on oculoplastic surgery. We're joined by Dr. Mark Ludwig, a leading expert in the field, to discuss complex eyelid lesions and their management. Thank you for joining us, Dr. Ludwig.
Thank you, Dr. Thompson. It's crucial to delve deep into the nuances of managing eyelid lesions, especially when they recur or present with ambiguous characteristics. Today's case study will provide a comprehensive overview of such challenges.
Let's begin by discussing the patient, a 57-year-old who presented with a lesion that initially seemed benign. Can you walk us through the initial presentation and what triggered the decision for a more thorough investigation?
Certainly. The patient presented with what was initially presumed to be a benign chalazion on the lower eyelid. However, the lesion recurred within a few months, displaying increased vascularity and slight ulceration. Given these changes, we opted for an incisional biopsy to determine the underlying pathology while minimizing damage to the delicate eyelid structures.
How do you assess and prepare for a biopsy in such sensitive areas?
The key is to balance diagnostic accuracy with the preservation of eyelid function and aesthetics. For this patient, we used local anesthesia and a fine needle to perform the biopsy, ensuring minimal trauma. We targeted the most representative area of the lesion, avoiding necrotic or ulcerated sections that might not provide viable tissue samples.
Once the biopsy confirmed basal cell carcinoma, what were your considerations for the surgical approach?
The diagnosis shifted our focus towards complete removal with oncological safety margins. We chose Mohs micrographic surgery, renowned for its high cure rates in skin cancers and its ability to conserve as much healthy tissue as possible. This method is particularly beneficial for facial and eyelid areas where every millimeter of tissue is crucial for both functional and cosmetic outcomes.
Could you elaborate on the reconstructive techniques you employed post-Mohs surgery?
After ensuring clear margins, we proceeded with a full-thickness skin graft harvested from the upper eyelid. This approach provides excellent color and texture match, essential for the lower eyelid, which is constantly visible and under scrutiny. We carefully sutured the graft to align with the natural eyelid contour, promoting optimal healing and integration.
What specific postoperative care did you recommend?
Postoperative management included antibiotic ointment to prevent infection and steroid eye drops to reduce inflammation. The patient was instructed to avoid strenuous activities and exposure to sunlight, which could exacerbate scarring. Regular follow-ups were scheduled to monitor the healing process and detect any signs of recurrence early.
In your experience, what are the common pitfalls in managing such cases, and how can they be avoided?
One common pitfall is underestimating the aggressiveness of eyelid malignancies. Early and accurate diagnosis, thorough surgical planning, and meticulous execution are key to avoiding complications. Another pitfall is inadequate patient education about the recovery process and expectations, which can lead to dissatisfaction or non-compliance with post-operative care.
Lastly, how do you approach post-patient consultations regarding potential disfigurement and the need for possible further surgeries?
Clear communication is crucial. I ensure that patients understand the severity of their condition, the proposed treatment plan, and the realistic outcomes they can expect. Discussing potential complications and the possibility of further surgeries up front helps in managing expectations and builds trust, which is vital for a successful doctor-patient relationship.
Thank you, Dr. Ludwig, for sharing your expertise. This discussion undoubtedly enriches our understanding of the complexities involved in oculoplastic surgery and emphasizes the importance of a meticulous, patient-centered approach.
Thank you, Dr. Thompson. It's been a pleasure discussing these critical aspects. Let's continue to strive for excellence in our field and ensure the best outcomes for our patients.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Good morning, and thank you all for joining. It's a pleasure to be here to discuss some of the groundbreaking approaches we are taking to understand and treat cerebrovascular diseases, specifically focusing on the mechanisms behind aneurysm formation and rupture. First, let's establish what we know about intracranial aneurysms. These are vascular dilatations that stem from weaknesses in the walls of cerebral arteries and pose significant risks due to their potential to rupture, leading to subarachnoid hemorrhage, a form of stroke that can result in high mortality and morbidity rates. Traditional treatments have included surgical clipping and endovascular coiling, which aim to isolate the aneurysm from the normal circulation without damaging adjacent vessels. However, complications from these procedures, alongside their invasive nature, underscore a crucial need for innovative, less invasive therapeutic strategies. Hence, our focus has shifted somewhat towards the pharmacological stabilization of aneurysms. Let's delve deeper into one of our recent case studies which has significantly shaped our ongoing research. This case involved a 58-year-old female patient who was diagnosed with an unruptured intracranial aneurysm during a routine checkup for recurrent headaches. Given the location and size of the aneurysm, traditional surgical options posed considerable risks. This scenario provided a real-world application for our translational research efforts, specifically exploring pharmacological interventions to prevent aneurysm rupture. Our research group has been developing a novel pharmacological male-ad approach aimed at targeting the underlying biological mechanisms that contribute to aneurysm instability. From our extensive studies, we've identified inflammation and vascular remodeling as key processes in the pathophysiology of aneurysm development and rupture. Thus, we've hypothesized that modulating these pathways could stabilize aneurysms pharmacologically and reduce the risk of rupture. To test this hypothesis, we used a rodent model mimicking human aneurysm pathology. It was to evaluate the efficacy of a new drug designed to inhibit MMP9, an enzyme significantly involved in the degradation of the extracellular matrix and vascular remodeling. Preliminary results in our animal studies showed promising decreases in aneurysm progression and rupture, suggesting a potential therapeutic benefit. Encouraged by these findings, we initiated a pilot clinical trial involving patients like the one mentioned, who had small, unruptured aneurysms that presented surgical challenges. In this trial, patients received the MMP9 inhibitor alongside standard care. The primary endpoints included changes in aneurysm size and morphology, assessed via high-resolution MRI scans over a 6-month period, along with biomarkers of inflammation and vascular remodeling in blood samples. Preliminary results from this trial have been encouraging. In our patient's case, MRI scans at the 3-month follow-up showed no significant increase in aneurysm size, and biomarkers indicated reduced inflammation levels. While these findings are preliminary, they suggest that pharmacological intervention could indeed alter the natural history of aneurysms. Our research is paving the way for a shift in how we might manage unruptured intracranial aneurysms in the future. By integrating clinical insights with translational research, we are beginning to unravel the complex mechanisms underlying aneurysm pathology and exploring new frontiers in non-invasive treatment strategies. Our ultimate goal is to improve patient outcomes through innovative research and therapeutic interventions. Thank you once again for your attention. I look forward to any questions and a fruitful discussion on these exciting developments in cerebrovascular disease research.